Good morning and welcome everyone to the second progress report. My PhD thesis is titled Adenomyosis and Infertility. Bit of introduction, my name is Máté Botos. I'm a first year PhD student and a third year gynecology resident at Székesfehérvár. My vision is to have improved pregnancy outcomes for women with adenomyosis, and through my project, my mission is to find the most effective assisted reproduction protocol for infertile women with adenomyosis. I have two ongoing projects to achieve my missions. Let me start with the first one. It's titled Investigating the Efficacy and Safety of GnRH agonist pretreatment before frozen embryo transfers in women with adenomyosis. So this condition, adenomyosis, is a condition where the endometrial layer invades the myometrium of the uterus. And the exact prevalence of the condition is not very well established, but studies suggest a prevalence between 12 to 58%. And not only do women with adenomyosis face a higher risk of infertility, but even with the use of assisted reproduction techniques, their chances to achieve clinical pregnancy is significantly lower than with those without the condition. And the GnRH agonist pretreatment works by downregulating the ovarian hormone production, and this way preparing the endometrium for hormone replacement therapy before artificial ovarian cycles. My aim is to investigate the efficacy and safety of GnRH agonist pretreatment before frozen embryo transfers in infertile women with adenomyosis. Therefore, our clinical question is that does GnRH agonist pretreatment safely and effectively increase live birth rates in infertile women with adenomyosis who are undergoing frozen embryo transfers? The population is women with adenomyosis undergoing frozen embryo transfers, and we would like to investigate the primary outcome of the live birth rates and the secondary outcomes of clinical pregnancy rates, implantation rates, miscarriage rates. And we would like to investigate these outcomes with and without the GnRH agonist pretreatment. Our hypothesis is that endometrial pretreatment can increase live birth rates in women with adenomyosis who are undergoing frozen embryo transfers. And the clinical implication of that would be to contribute to assisted reproduction guidelines for women with adenomyosis. We have conducted a systemic search in November in 5 databases with over 6,000 results. You can see our selection process summarized in a Prisma flowchart. It's a bit tiny, but you can see that we have 9 articles included in total. We also did the risk of bias assessment of these articles. You can see that we have 2 randomized control trials included and 7 retrospective cohort studies included. And now let me present the outcome, our primary outcome in frost plots, which is live birth numbers. We have 2 separate plots because some of the articles report the population number as the total patients who are included in the studies, and some report the total IVF cycle numbers. And we chose the live birth outcome as the main outcome because live births are the ultimate goal for the IVF treatments. And you can see in the first plot, where the per patient live birth numbers are included, that we included 4 studies. 1 of them were on RCTs, and the 3 of them were retrospective cohort studies. In total, we have more than 700 patients included. You can see a heterogeneity of 0%, but with a wide confidence interval, so this can be attributed to the low number of studies included. We also have a pooled odds ratio for live births at 0.99, indicating that the GnRH agonist pretreatment didn't have an effect on the live births in these populations. And the second plot, we have 7 studies included. 1 of them also were an RCT, the rest were retrospective cohort studies. We analyzed more than 1,500 IVF cycles in these populations, with a quite high heterogeneity, of course, because as you can see in the odds ratios of the first and the last 2 studies included that we had outcomes in the complete opposite direction, statistically significant outcomes in the completely opposite direction. We have a pooled odds ratio of 1.13, but since this high heterogeneity in the articles, we can't really interpret these numbers until we find an answer for why the high heterogeneity is observed in these studies. One possible solution would be to take a look into the length of treatments or the severity of adenomyosis in these patients, because these vary between the studies quite significantly. Our progress is summarized in this slide. You can see that the grade assessment and the manuscript writing is still ahead of us. And of course, we try to collect some strengths and limitations for this study. One of the strengths would be the very rigorous methodology that we use, and that the studies we included were really good quality, I believe. And the limitations are the low case numbers that we could identify and the low articles we could include, and that they were mostly retrospective cohort studies, only 2 were RCTs. And we have collected a couple of conclusions for these results. And the first one is that the GnRH agonist administration has no general advantage during frozen embryo transfers in increasing live births. But certain patients can benefit from the GnRH agonist administration, and that the different lengths of treatments can result in different outcomes. And for our clinical practice, this means that the GnRH agonist administration has to be assessed on an individual patient level, and that certain patients, it can be beneficial in increasing live births. And the implication for research is that we need further randomized studies to find out which specific population can benefit the most from the pretreatment, and we have to assess the length and the dosage of the treatment to find out the best way of administration. Now on to the second project. It's titled Comparing the Efficacy and Safety of Fertility-Sparing Treatment Options for Adenomyosis. In the first part of the presentation, we discussed the effect of adenomyosis on infertility, but it also causes several significant issues like dysmenorrhea, abnormal uterine bleeding, and pelvic pain. For the infertility part, we can use the assisted reproduction techniques, which we discussed, but the other issues need medical or surgical treatment. Our study focuses on the surgical treatments, which include excisional surgeries, for example, adenomyomectomy, or non-excisional surgeries, like different ablation techniques or uterine artery embolization. The excisional techniques are known to raise the risk of uterine rupture in later pregnancies. Therefore, finding the safest option is critical. The non-excisional techniques also offer an alternative to patients who are not eligible for conventional surgeries. My aim is to find the safest, most effective fertility-sparing treatment option for adenomyosis. Our clinical question is that which fertility-sparing treatment option is the safest and most effective in reducing symptom severity in women with adenomyosis. The population are women with adenomyosis. The interventions are the ones I listed earlier, and the outcomes would be also primary and secondary. The primary will be the effectiveness in reducing symptom severity, and the others are reproductive outcomes and the adverse effects. My hypothesis is that minimally invasive techniques are safe and effective treatment options for adenomyosis. Our clinical implication would be to provide a clear guide for medical professionals treating women with adenomyosis. We've run a systemic search with 5,000 hits, and we already done the title abstract selection, and we are left with the full text selection. In summary, we have 2 ongoing projects, both related to adenomyosis and its treatment options. We plan to submit the first article by this September, and the second one at the January of 2026. Thank you for your attention.
Thank you very much for an excellent lecture. Has everyone question from the front?
Yeah, I have one. Congratulations, nice
Thank
presentation. Do you have an idea what is the cause of that certain population that has benefits using GnRH agonists?
Well, we tried to take a look into the data of these articles, and we saw that in the article that they were reported a negative effect. Those populations had severe adenomyosis patients. So we hypothesized that severe patients may not benefit that much from the treatment, but not the severe cases might do.
Thank you so much.
Thank you.
Thank you very much. Congratulations for this amazing progress. So only 6 months has passed and you already are writing your first manuscript. Congrats.
Thank you.
And really way down in the selection with the second. Congrats again. So my question or my remark was regarding the previous question from our colleague that, I mean, you wrote this among the conclusions that for certain populations it can be beneficial, but next time you present this topic, you should highlight at which population, because a big question mark remained in me. So next time please include it in your talk. And the other thing, can we go back to the strengths and limitations? Yeah, so I agree with rigorous methodology. However, the risk of bias assessment, I believe you that the methodology was appropriate and you use the right tools, but you only have 2 RCTs and 5 retrospective studies, which I would, for me, in case of retrospective cohorts, it's highly questionable the quality of them in general. So maybe I would remove it from the strengths to avoid or just to downscale it a bit. Don't overstate that the quality of your results, because most of them are coming from retrospective papers. And can we go back to the results too? Yeah. So this is really interesting and maybe something that you should highlight in the discussion, that although the live birth rate per patient seems to be similar, the live birth per IVF cycle seems to be better with the drugs used, like this 1.13 odds ratio. But this is a good thing, right? Because you need less IVF cycles, and it shows to me that the efficacy of the IVF is better if you use GnRH agonists, right? So the probability of having a live birth per cycle is better, meaning that you can improve the IVF cycle itself, which can lead to better cost effectiveness of the cycle.
I think because of there is one outlier, at least one outlier in this plot with the first article with the negative effect. It makes the pooled effect not statistically significant, because it's only like a 10% higher odds ratio. But if we could find out the reason why this first article has this harmful effect, and maybe we can come up with a solution to analyze the patient.
Did you come up with a solution, or did you find, for example, in that paper that for patients with severe adenomyosis, it's bad? Or
well, we have hypotheses, or
so there is no data in the.
There is only one article with the harmful effect, which we can analyze. So it's only like a guessing game. But in the article they said that some patients might require 1 month of treatment, some patients more than 3 months. We don't really know the proportions of the patients who required more than 3 months treatment. How long the treatment was? Maybe it was more than a year. Maybe.
Sorry, just one more remark. Really at the end, it's like using causal language and accepting the null hypothesis. So in hypothesis testing, you said that GnRH agonists didn't have an effect on live birth rates. Well, you should. So this is not good that you said this, because with this you accept the null hypothesis. But rather this, based on the quality of the studies and based on the hypothesis testing, you should rather say that we failed to find evidence to disprove our null hypothesis. So the null hypothesis is we never prove it. We want to disprove it, but you can say that we failed to disprove our null hypothesis, but we'd never accept it.
Okay, thank you.
Thank you for the nice presentation. I also would like to have a question for the first part of your topic, that how was the adenomyosis assessed, and whether you were also checking if these patients had endometriosis, because it's a far amount of patients with adenomyosis, they have also endometriosis.
Yeah, this population, most of the articles included didn't exclude patients with adenomyosis, since this is a common comorbidity of patients with adenomyosis. Most of the patients, or at least a part of the patient population, also had endometriosis. That's true. And regarding the other question, the assessment was done by ultrasound findings. It was all of the articles listed every criteria that they needed to match to be included.
It was the MUSA criteria, or some previous?
It was some of the articles used the MUSA criteria. Some used their own diagnostic criteria.
Okay, and for the second one, that it's like what you were talking about, that these surgeries are only approved in the case of the adenomyoma when there's a localized adenomyosis. And it's like, how many percentage, according to your knowledge, the adenomyosis is diffuse, because it's mainly a diffuse disease, and how many times it's localized? Like, what is the percentage of the localized adenomyosis?
I don't really remember the exact number, but more patients have the focal adenomyosis. More than half of the patients have the focal adenomyosis, and less than half they do have the diffuse adenomyosis, I think.
Well, I think it would be good to maybe have some numbers about that, because
yeah, I believe
in clinical practice, it's what we see. I can't say an exact numbers either, but it's a much higher percentage, the diffuse.
Yeah, maybe these articles are like a bit biased in the population, because the patients who are treated surgically are mainly the focal ones, and they have...
Yeah, exactly. So I think it would be worth to highlight this, that these are on the focal adenomyosis, what you were talking about there. Thanks.
All right, thank you so much.